joining us today. On behalf of the Radiology Society of Rio de Janeiro and OCAD, I'm glad to welcome and thank you all for being here today. My name is Aline Serfati, and I'm honored to co-host this session alongside Dr. Hilary Humans, who has been coordinating and moderating this series with me since 2021. Our guest speakers today are Dr. Renata Leão, Dr. Angela Atinga, and Dr. John Jacobson. Together, they will present a series of interesting cases highlighting the most relevant imaging findings and providing a literature review to enrich the discussion. And as an exception, Dr. Jacobson will take questions immediately after his presentation, as he will need to leave shortly afterward. The other two presenters will take questions at the end of the session. If you have questions at any time during the presentations, please put them in the chat box, and at the end, the speakers will respond to them. The presentations today will be recorded and available on demand on the OCAD website, which is ocadmsk.com, and on the YouTube channel of the Radiology Society of Rio de Janeiro. If you want to join the OCAD community and see challenging cases, consider registering on the OCAD website. Hilary has also launched the OCAD channel on LinkedIn, so you can also check out amazing cases in the quizzes and stay updated about the sessions there. Okay, Hilary, please kick off the session.
Okay, hi everybody. I'm very excited to introduce my friend and colleague, Dr. John Jacobson. He completed his radiology residency at Henry Ford Hospital in Detroit, Michigan, and musculoskeletal fellowship at the University of California in San Diego. After working for 23 years at the University of Michigan as division director and professor of radiology developing their musculoskeletal ultrasound program, Dr. Jacobson currently works with me at Lenox Hill Radiology in New York City and also at University of California in San Diego, although momentarily he'll be returning to the University of Michigan. Dr. Jacobson's research interests include musculoskeletal ultrasound and MRI. His academic achievements are many, including over 260 peer-reviewed publications and many invited national and international lectures or workshops. He's been a visiting professor on over 50 occasions and is president of the Society of Skeletal Radiology and has received numerous teaching and mentoring awards, including the 2023 Distinguished Educator Award of the American Rankin Ray Society. I think many of us know that he's the author of the textbook Fundamentals of Musculoskeletal Ultrasound, which has been translated into 5 languages and is now in its 3rd edition. Okay, John, share your screen.
This case has to do with elbow ultrasound. This was a patient who presented to my clinic. He's middle-aged, whatever that means, manual laborer, pain with pronation and supination, where he could pinpoint with one finger where the problem is. The radiographs only showed mild osteoarthrosis. Here's an ultrasound looking at the radius and the ulna, looking at the dorsal aspect. And when the patient pronated, which I'm showing right now, the distal biceps is moving dorsally between the ulna and the radius. And you can appreciate the snapping that was very painful during this maneuver. In the video on the right, we see the same thing happening, now appreciating the hypoechoic appearance and the calcification of the distal biceps. As you can see, with hyperpronation, the radial tuberosity will then come out more dorsally. So the topic of this talk has to do with snapping conditions of the elbow and reviewing this as well. So this is what the ultrasound showed, as I just mentioned, the tendinosis, enthesopathy, calcification, impingement, and no bicipital radial bursitis. So just a few comments I'd like to make regarding ultrasound scanning of the biceps. Definitely one of the more challenging applications. There are 4 different approaches. I highlight anterior and medial because I perform those in every patient. I start anterior, looking for normal or retracted tears. I'll often go medially, usually I will, to help get rid of anisotropy. A lateral approach, I'll problem solve when I'm trying to distinguish partial from full thickness tear. And then finally, what I'm showing with this case is the dorsal view, which really has limited diagnostic information. However, in some situations, like the patient I just reviewed, it was essential. But I do use this view when I guide biceps tendon injections. A few comments on the anatomy. We know that the two heads persist all the way to the radial tuberosity. You can see the short head is medial, the long head is lateral, and over the last several centimeters, there's a twisting so that the long head goes underneath the short head with a broader attachment. Again, there's no synovial sheath, so you should not see tenosynovitis, but rather there's a bursa, the bicipital bursa. So when performing ultrasound from an anterior approach, this clamshell appearance is my home base to show my starting point. Now, without anisotropy, the biceps looks like one tendon, but we know that there's an endotenon septum here, that if you toggle the transducer, you bring out anisotropy of the tendon, which does not demonstrate this with the septation. So you can indeed see the short head and the long head, medial is on the right. And as we go distally, the long head will go underneath the short head. Here, taken from the literature, medial is on the left. Again, the short head is more medial compared to the long head, but as we go distally, the long head goes underneath. So that when we're looking at the distal biceps from an anterior approach, we know that the outer 50% or superficial 50% is indeed the short head, and the deeper part the long head, although sometimes it's difficult, often difficult, to distinguish the two when they both are normal. Now, the medial approach, what has been described as a pronator window where the elbow is bent, I typically don't use this exactly. I'll have the elbow extended and have a more oblique approach to an anterior scanning, but nonetheless, this is another way to eliminate anisotropy and see the tendon at perpendicular. So I always scan anterior. I usually always scan medial as well. Now, if I see a problem and I'm trying to decide partial versus full thickness tear, then I use this lateral approach with dynamic imaging. Here we see the radius, the supinator, and there's the biceps tendon. And with supination and pronation, you can see movement of the biceps equal to the rotation of the radius. Now, from this position, the radial tuberosity is hidden from view, but I've already looked at that medially. Here's a case of a partial tear where when I'm rotating pronation and supination, the abnormal tendon is still connected or tethered, so that is not a full thickness tear. In contrast to this case, where what we see is a rotation of the radius, and this thickened biceps tendon does not translate at all. That tells me it's a disconnect and a complete tear. Now let's get back to this dorsal view. It's been called the cobra view, but essentially it's a dorsal hyperpronated flexion view. And what we see here dorsally is the radius and the ulna. In supination, the radial tuberosity is on the other side, like the dark side of the moon. But then if we pronate, that's when it rotates into view. Again, we only see the the distal 1 centimeter or so, so it's of limited diagnostic value, with the exception of the case I just demonstrated. So here's an example with tendinosis of the distal biceps. And you can see as we go from supination to pronation, that's pronation, and then supination, it's hidden from view. Again, dorsal's out here. Back to pronation, we can see it. And this is a case where I fenestrated it and injected whole blood as a biologic treatment to take care of the tendinosis. But this is a great way to access the biceps tendon. Very easy to do, with the patient laying there holding the hand in pronation, the needle coming in from this side. So just to wrap this up, there are some other causes of snapping elbow that you should consider. They're listed here. I don't have an example of brachialis snapping over the lateral humerus. Several of my colleagues have shown me examples of this, so it's not rare. All these are somewhat uncommon, at least the bottom three are. So of course, ulnar nerve dislocation, if you position the transducer in the axial plane over the medial epicondyle, the ulnar nerve should stay behind or posterior to the epicondyle during flexion. Abnormally, it will move over the top like this. Make sure we don't push too hard with the transducer because you can inhibit this movement. This can occur in 20% of the population who being asymptomatic. Now we have to distinguish that from snapping triceps syndrome. In this scenario, not only does the ulnar nerve dislocate, but the medial triceps will subluxate. Here is the ulnar nerve, and it's going to snap anteriorly right there. And then there is the medial aspect of the triceps. So both of these are moving over, and it can produce two different snaps. A snapping annular ligament is uncommon. It's been described really in two different situations. First of all, nursemaid's elbow is when it's actually with radial head subluxation, it is somewhat displaced, but by the time the radiographs are taken, it tends to relocate. So we typically don't see this at imaging, but here's a case in an athlete where it's been described you can have degeneration and hypertrophy of the annular ligament, and you can see this snapping back and forth. This was painful, the patient pointing right at it, and this can be debrided as a way of treatment. And then finally, synovial fold syndrome. This is an excellent article that you should take a look at. They describe this synovial fold or plica, that it can be irregular. Here we can see a case where there's a cleft in it and synovitis, and this was focally symptomatic with supination and pronation. You can see this kind of moving around a bit. And in the bottom case, a companion case, where we see actually subtle snapping of this synovial fold. Again, painful, and they will resect this or debride it as a way of treatment. On this QR code is how you can get to the syllabus for this lecture if interested. So I can take any questions now.
I don't see any questions of the audience. Do you have any questions, Hillary?
No, that was beautiful. So just for those of us who haven't done those elbow injections, you said you use that that Cobra approach to guide the injections. Where exactly are you guiding the needle from? From lateral to medial, or?
So with the patient's elbow flexed and hyperpronated, I'm basically coming from the ulnar asp, coming over the ulna and hitting the radial tuberosity area. You can come from over the radius as well. Typically, a branch of the posterior osseous nerve is there, and you just have to avoid that. But it's really easy to avoid, unlike trying to approach the distal biceps from an anterior approach where there's a lot of things in the way. So I usually come over the ulna, but you can come over the radius as well, in plane, somewhat short axis to the forearm.
And there's no point in anesthetic and steroids for synovial fold syndrome?
I haven't been asked to do that, but I certainly would entertain that, especially that first case where there was some synovitis. Before, especially if I had that, I wouldn't go to surgery right away. I would definitely throw some steroids in there and rest it, and some physical therapy helps everything. Usually it can. I would do the steroids first.
Okay. I'm out of questions. Thank you, John. That was.
Thank you, John.
Okay, thank you for listening to me and attending. And I got to run. Thanks for accommodating my request. Have a good day, everyone.
Bon voyage.
Bye.
Safe travels.
Thanks.
I see there's one question for you, but he can email you as you're running to the airport. It's from Pablo.
Okay, great. Thanks.
Okay. Now it's my great pleasure to introduce Dr. Renata Leão. She is a musculoskeletal radiologist who earned her medical degree from the Federal University of Pará in Brazil and completed a fellowship in MSK radiology at Hospital Sírio-Libanês in São Paulo. She's a member of the International Skeletal Society and the Society of Skeletal Radiology. Dr. Renata Leão is currently in her early years as an assistant professor of radiology at the University of Iowa, and is pursuing a PhD in radiology with a research focus on advanced imaging evaluation of knee injuries. Her main interests include peripheral nerve evaluation and musculoskeletal MRI. Please, Renata, take it away.
Hi, you can all hear me?
Yes.
Yes. Thank you, Aline, for the introduction, and thank you, Aline and Hillary, for the invitation. I am a big fan of OCAD, so I'm really happy to be here today. So I'll start with my first case. That's a 64-year-old male. He had a 3-week bilateral hip greater than shoulder pain, stiffness, limited range of motion, fatigue, and anorexia. He had a TBC showing mild anemia and elevated RCP and ESR levels, and he had normal shoulder and hip radiographs. So he got this pelvis MR, and we can see the coronal stir and coronal T1 post-contrast images. And I hope we can appreciate how he has these very severely thickened hip capsules bilaterally with a lot of edema involving the capsules. And he also had this mild effusion. In the post-contrast sequences, we see that there's a lot of post-contrast enhancement along the capsules, also bilateral. There's mild synovitis as well, but I'd say that the most marked findings are really centered in the hip capsules. And we have the axial images here. Again, we see a lot of edema around the capsule. Some of the edema changes we see kind of extending to the myotendinous junctions, so to the muscles around the hips bilaterally. And we see it even here also in lower levels. And again, this post-contrast images showing pretty much the same things. He also had a PET-CT, so we can nicely see here how he has this very high uptake around the hip joints and also within the hip joints bilaterally. So I'll just go straight to my second case. That's a 72-year-old male, also with bilateral hip pain, shoulder pain, stiffness for 45 days. He had mild weight loss, fatigue, again, CBC showing mild anemia and elevated inflammatory markers. And he also had a pelvis MR, and we again see this very thickened capsule with a lot of edematous changes within the hip capsules bilaterally and around the capsule, also extending to the muscles, gluteus muscles, to the myotendinous transitions. Here are the axial images, again, some edema around the capsule and extending here to the myotendinous transitions bilaterally as well. He also had shoulder MR, and we see some rotator cuff tendinosis, but mostly a lot of thickening and edematous changes around the capsule, the glenohumeral capsule. Again, some effusion and maybe even synovitis, although we don't have here the post-contrast images, and a lot of edema again around the rotator cuff and extending beyond the tendon insertions to the myotendinous transitions and to the muscle bellies. Here we can see at the subscapularis and at the infrascapularis as well. He also had a PET-CT. Again, we see high uptake around the shoulders and around the hips bilaterally. And finally, that's my third case, a 75-year-old female, bilateral hip and shoulder pain and stiffness for 2 weeks, anorexia, normal CBC, but elevated RCP and ESR levels. And she also had a shoulder and hip MRs. And again, we see edematous changes around the glenohumeral capsule, some glenohumeral effusion, a lot of edema around the shoulder, extending along the rotator cuff tendons to the myotendinous transitions, to the muscle bellies, just going beyond the insertion of those tendons. The left hip showed pretty much similar findings with, again, capsule edema all around. Like we can see in the sagittal images how the edema extends along the capsule, along the anterior iliofemoral ligaments. And in the axial images, how we have also some mild edema extending to the myotendinous transitions as well. And again, here, some capsule thickening and edema. So I hope what we can appreciate in those 3 cases, those similar findings. So they were all cases in patients older than 60 years old. They had constitutional symptoms, anorexia, weight loss. They all had bilateral shoulder and hip pain, stiffness, and elevated inflammatory markers. And in terms of imaging, they all had these very marked periarticular findings. So a lot of capsule edema, a lot of peritendinous edema, and other findings as well as mild effusion in the hips and shoulder, and also some bursitis, as we can see here. So what kind of wraps up those cases together is a diagnosis that is very well known by hematologists, but maybe not so much by us, by radiologists, which is polymyalgia rheumatica. And I'm just gonna call PMR just to help myself here, but PMR is this chronic inflammatory disease. It's very common in individuals older than 50 years old. It peaks around 70 and 80 years old. And it's characterized by this inflammation in the articular and periarticular structures of the shoulders and hips. And the symptoms are pretty classic with a lot of pain and stiffness in shoulder and hips, and also along with those systemic symptoms like fatigue, anorexia, weight loss, and even fever sometimes. So it's basically a clinical diagnosis. We don't have any laboratory tests to confirm that. But we do have some imaging findings. They are actually included in the classification criteria from the American College of Rheumatology. So among those criteria, among the criteria here, we have as required criteria that the patients should be aged 50 years old or more. They should have shoulder aching, abnormal inflammatory markers, with or without those other associated findings that include hip pain, and also some imaging findings as usually can be seen on ultrasound as subdeltoid bursitis, biceps tenosynovitis, glenohumeral synovitis, and hip synovitis and trochanteric bursitis. So all those imaging findings that are included in the classification criteria here for PMR, they are pretty common and I think we all who read MRs from elderly patients, we see that a lot. And usually we don't think of PMR in patients who have biceps tenosynovitis, subacromial bursitis, just because those findings are pretty non-specific and very common in elderly patients with osteoarthritis. But we have been able to see that those patients, they also frequently have those slightly more specific and not so common periarticular changes as the capsule edema, the peritendinous edema that goes beyond the tendon insertions towards the myotendinous junctions. And this can be pretty helpful. And I think I have those images here again. So those capsule edema, these inflammatory changes around the joint. So that's not so common as the other findings that we have classically described for PMR. So that's where I think this diagnosis could be something that we should start to consider when we are reading those shoulder and hips MR. So usually what we have is like patients, they have this new onset pain and stiffness in the upper and lower girdles. They're usually patients with more than 50 years old. So rheumatologists are really used to this diagnosis, so they may request the ESR, CRP levels. They are going to rule out other disease as rheumatoid arthritis. They're going to also rule out some symptoms related to giant cell arteritis, because we know there is a high correlation between PMR and giant cell arteritis. So they're going to rule out this upper extremity claudication, jaw claudication, headache, and they may or not request ultrasound, since we have some ultrasound findings included in the classification criteria that we talked about, those not very specific findings, and may or may not request MR. I feel like MR is being more easily assessed by patients. We see more and more MR, so we may end up facing all those changes that we may see in PMR as this very severe periarticular soft tissue inflammation in shoulders and pelvic girdles. So that's how the picture of the PMR looks like, and having that, we should think of this diagnosis. So just before I finalize here, I have these other cases, so no history initially, but we have this left hip MR. We see a small to moderate effusion. There is a lot of edema around the capsule and also extending beyond the capsule and involving the muscles around the hip. But this was a 55-year-old patient with pain, fever, and elevated white blood cell count, and it was septic arthritis. Also, this other patient is a younger patient with a lot of edema around the hip capsule, a lot of some effusion as well, but this was a 16-year-old falling in trauma. And also he had this insertion here, this injury to the femoral insertion of the iliofemoral ligaments. So this is just to show that of course, not all capsule edema are going to be thinking of PMR. It's many times an exclusion diagnosis, but it is definitely something we should start thinking about. And I have this last case, I forgot about that. And that's a 55-year-old, he has pain, limited range of motion, and we can see how he has this asymmetric and actually just very severe thickening and edematous changes around the right hip capsule. But I hope we can trust me and appreciate this focus of low T2 and T1 areas here within the capsule near all those inflammatory changes. In the axial images, we can see it as well here on T2, on T1, and here at the anterior margin of the acetabulum. Those were soft tissue calcifications and with associated inflammatory changes in the capsule. Unfortunately, I don't have the x-ray for this one, but it was pretty convincing as we were scrolling up and down on this patient. So that's probably just a calcific capsulitis. So just take home message here. So I talked a little about hip capsule disease. I was focusing on polymyalgia rheumatica. So it's a disease of elderly patients with marked periarticular inflammatory changes in shoulder and hips. And we should think of it in those elderly patients who have these high inflammatory markers, bilateral symptoms, and the image findings that we just mentioned. Okay, of course, we should always rule out infection, crystal deposition, trauma, rheumatoid arthritis, and all that. But I thought I could bring those cases because, at least for me, it was not a diagnosis that I would consider before when I was reading some of those MRIs, but that's something I'm starting to think about and seeing more frequently in the daily practice. That's what I have, and those are just some papers on this topic that we recently published, and thank you so much.
Renata, that was fantastic. I know that we're going to have a few questions for you at the end.
Thank you.
But right now, I'm going to shift gears and introduce my good friend, Dr. Angela Atinga, who completed clinical and research fellowships in musculoskeletal radiology at the Joint Department of Medical Imaging in the University of Toronto in Canada. She is the musculoskeletal radiology division lead at Sunnybrook Health Sciences Center and an assistant professor at the University of Toronto with a special interest in multimodality trauma and sports imaging and the clinical applications of machine learning methods to musculoskeletal radiology. Okay, Angela, it looks like you're one step ahead of me.
Hi, everyone. Thank you so much for joining us today. We're going to shift gears quite dramatically from what we've seen so far to just think about something that we all know about, but perhaps think about it in a different way, more so the way our surgeons think about patella instability. So I find this a bit of a nightmare because it's the only bit of radiology that I have been unable to overcome the need to use rulers, ratios, and angles, no matter how hard we try. So hopefully I'm going to review the imaging findings in patients with patella instability, discuss the assessment of trochlear dysplasia, patella alta, and TTTG assessment, and highlight current concepts in patella instability assessment and management. So I'll start with the case of a 26-year-old female who presented with a traumatic injury. The exact mechanism is unclear, but she was playing sports. She felt a pop, which spontaneously reduced and went to an emergency department, not with us, where she had radiographs and an MRI at the time. Her radiographs showed a small hyperdensity in the intercondylar notch anteriorly. You could see that the patella looked abnormally positioned. Doesn't matter that it wasn't on an axial view. This did not look like a normal position. And she also had a little bit of an effusion and swelling. They weren't entirely sure of the diagnosis at the time. They thought it was probably a patella instability event, and so she went on to have an MRI just to confirm that. And on the MRI, you can see the bony contusions with the yellow arrows here. So she has a contusion of the lateral margin of the femoral condyle, usually involving the anterior third, but depending on the degree of flexion, the edema can extend further posteriorly. She also had extensive edema in her entire patella. So classically, the books will tell you inframedial, but this patient had edema throughout her entire patella. The yellow arrow highlights a defect in the MPFL attachment at the patella. And critically here, the white arrow showed that she had an osteochondral or at least a high-grade chondral defect at the time. So she was referred to sports medicine, but as happens, was lost to follow-up. And so she was presented to our institution a year later with worsening pain, a lot of stiffness, but also a feeling of giving way. She reported a history of actually over 10 dislocations, which was not apparent at the previous visit. And the last one was that first MRI that we saw. She had significant apprehension, and even just testing and extension did not want anyone to touch her patella. And she got to the point that she was using crutches to ambulate, so no longer able to take part in sports or do anything. So diagnosis of objective patella instability was made. So if you think about the way you classify patella instability, you'll have objective, where you have a documented dislocation and at least one confirmed anatomical risk factor. Potential patella instability, where patients will present with pain, an anatomical risk factor, but no documented history of dislocation, be it on radiographs, clinically, or MRI. And then the third category of patients with patella symptoms, possibly instability, are the painful patella syndrome group. These are patients who have pain, sometimes will describe apprehension, but they have no history of a dislocation or any anatomical risk factors. So we repeated a whole host of imaging when she came to see us. The first view here is the long length view of both lower extremities, which I'll go through in a little bit more detail. She also had additional radiographs, in particular this axial view here. So we tend to obtain a merchant view, which is done in shallow flexion, almost about 25 to 30 degrees, as opposed to a deep skyline view. We also performed PA flexion radiographs, and the key thing here is just making sure that she didn't have any other signs of osteoarthritis or subtle joint space narrowing, pointing to additional pathology, and a good lateral radiograph, or hopefully a good lateral radiograph, where we assess not just patella alta, but also looking at the morphology of the trochlea. We repeated the MRI, and a lot of people ask why. So usually in the acute setting, patients have so much pain that it's difficult for them to tolerate a knee coil in that appropriate 20 to 30 degrees of flexion. And that's important because all of the measurements that we take in patella instability are really standardized with patients in this position. So we repeat the MRI just to get them in the correct position. And the other key thing is just to assess any chondrosis in the patellofemoral joint, because if you have severe OA, then perhaps, patella stabilization is not the best thing, and the patient may go on to a patellofemoral isolated arthroplasty. So these are just some of the measurements that we obtained on her MRI. Again, just repeating the patella alta measurement. So I'll go through this in a second using the Caton-Deschamps method. We also measured the TTTG, which didn't look particularly exciting. It was about 16 millimeters. But we also do the same thing again on CT. And on CT here, you can see this extensive dysplastic trochlea here with a cliff-like morphology. And actually on CT, the TTTG was much higher. And we know that this is common in the literature, that TTTG measured between CT and MRI tends to differ, with CT numbers being higher. So our surgeons will tend to get both of these images prior to thinking about surgery. So just to think about trochlear dysplasia and radiographs, I was obsessed with this for a very long time during my residency and fellowship, not so much now. But just to remind you that if you're looking at trochlear dysplasia A, where you do have a trochlear groove, but it's shallow, you're going to see this crossing sign on the radiographs, and this is going to be the morphology in MRI, but you don't really have a supratrochlear bump. Contrast that to this case here, where now you're getting into a more flatter trochlea here, where you have this supracondylar bump, as well as this crossing sign here. And that crossing sign is what's telling you that the groove is shallow. And then in this case here, what you're looking for in trochlear dysplasia is C on your lateral radiograph is this double contour here that shows you that the medial femoral condyle is hypoplastic. So it's not just a shallow groove, but the condyle is hypoplastic. And then finally, you have this cliff-like morphology, as we saw in our case, where you'll have all of the findings of a crossing sign, a supratrochlear bump, a double morphology. Somebody asked Hillary, and this is what kind of inspired my presentation today, is looking at quantitative measures of trochlear dysplasia. There are a number of them that are described in the literature. So you can look at trochlear facet asymmetry, the lateral trochlear inclination angle. So just for this facet asymmetry, so 0.3 or less is asymmetric and shallow for the medial facet. Lateral trochlear inclination angle, you're looking for an angle of at least 11 degrees or greater. And then this is a surrogate measure of the trochlear depth, looking at about 3 millimeters. But there are some controversies associated with this. It's always nice to have numbers attached to them, but you have to ask the question is, are the measurements validated? If you're looking at the cartilage or the bone contour, the Furman method was validated to the bone contour, but the cartilage in the patellofemoral joint is very deep. It's part of the largest in your body, contributes a lot to stability. So where should we be measuring? The idea that we measured 3 centimeters above the joint line seems nice and simple, but it's problematic because the more you read, the more you realize how much anatomical variation there is. And the qualitative assessment of trochlear dysplasia, do we really need to know all those 4 categories, or there are certain characteristics associated with low or high grade dysplasia? Similarly with patella alta, this is just a revision for everybody, but this is the screen left here where you can see my arrow is the Insel-Salvati method and the modified Insel-Salvati method. This is the Caton-Deschamps method here. And on MRI, you can measure the overlap between the patella and femoral trochlear cartilages. Again, some of these have been pretty well validated in terms of inter and intra-rater reliability, but in terms of patient symptoms, not so well. So IS doesn't correlate that well to patient symptomatology. CD ratio is moderate to good correlation, but actually is preferred by the surgeons because a lot of their surgical literature highlights this. So this is what our surgeons prefer. But on MRI, I will mention the patellotrochlear index as well. And just to make sure, check the values between radiographs and MRI every time I report because they're not consistent. And then finally, tibial tubercle lateralization, which I think is pretty standard and is measured the same way everywhere. I guess the only question is if you have a patient like ours where the trochlear dysplasia is so severe and you can't find the groove, should we be thinking about using another method? And you'll see a lot in the literature about the TT-PCL, which assesses lateralization but does not require the trochlear groove for assessment. And then finally, just thinking about femoral torsion, which is something that we do a lot of now. So we get these long length views. And the key thing here is looking for excessive valgus angulation across the knee, which has been associated with an increased risk of patellar instability. So we will measure this Y angle here, which is the lateral distal femoral angle, and it's the mechanical one, and compare that to the proximal medial tibial angle, obviously on the same side. I've just put them separately so you can appreciate that. And if the lateral femoral angle is much smaller than the medial tibial angle, then the patient has excessive valgus angulation. And the other thing is if they have excessive femoral torsion, you can measure that however you do at your institution. This is just an example of what we do here. So you're going to compare the femoral neck angle to the horizontal versus the posterior condylar angle to the horizontal. And if you have excessive femoral antitorsion, then these are additional anatomical factors that will predispose to instability. So our surgeons will actually consider performing an osteotomy in these patients. So let's just think about what the surgeons do. Well, their criteria that we use is if it's an irreducible dislocation, doesn't matter what else is going on, the patient's having an operation. If they have an osteochondral lesion, the literature shows that these patients do better if these are fixed earlier. And that fixation really depends on the size of the fragment, the quality of the fragment, and the acuity of the injury, trying to get these patients in sooner rather than later. And then again, the number of dislocations. So we know that if you have a first-time dislocator, you may end up being okay, but by the point you have a second dislocation, you're looking at a risk of dislocation of about 1 in 2 patients. And this is traditional. I think it's slowly being superseded with a greater tendency towards operation, even in first-time dislocators, particularly if they have risky anatomy. That brings me to this distinction between different patients based on clinical and radiologic features. So patients who have a weak atraumatic mechanism but very risky anatomy presenting with pain and subluxation events, and patients who have good anatomy, but they have a strong single isolated traumatic event, which results in instability and dislocation. You can try and stratify patients into one of these two groups, and the surgeons do, but often patients will have mixed features. So in our case, our patient had an osteochondral lesion, probably not repairable given that it was predominantly cartilage, but she'd had a large number of dislocations, has this risky anatomy with patella alta and trochlear dysplasia, as well as elevated TTTG, and she had pain and subluxation to the point that she was walking in crutches. So what are the surgical options? Well, the surgeons are going to have to think about the soft tissue and bony anatomy here. So the MPFL being the critical structure here when you're looking at your soft tissue anatomy, and then thinking about your tibial tubercle lateralization, as well as the trochlear if you must. So this is what they would do if they're doing an MPFL reconstruction here. So our patient would definitely be a candidate for this. And then the tibial tubercle transfer will have a combination of both anteriorly moving the tibia and medializing it, anterior because you want to take pressure off the patellofemoral joint, and medial because you want to take away that elevated TTTG. And then trochleoplasty in some cases, although this is really not a favored option because it's very, very surgically taxing. And if a lot of patients will do well with simply an MPFL reconstruction or tibial tubercle osteotomy without needing a trochleoplasty. So they'll try that first. If instability persists, they might come back to this. The exception to that is patients with isolated, very severe trochlear dysplasia, for example, in congenital disease, may have this as first-line treatment. Problem with this is that you're going to be interfering with articular cartilage and can predispose to increased rates of patellofemoral osteoarthritis. So this is what the flowchart that our surgeons use. So positive J sign, or basically if you're subluxed, we'll tell them that they need to do an MPFL reconstruction. Based on imaging, they'll look at your patella alta. So we use a Caton de Champ, and they'll add in a tibial tubercle distalization to eliminate that patella alta. If the TTTG is elevated, they will distalize and medialize. And then if the patient has junior valgum or excessive torsion, then they'll think about adding in usually distal femoral osteotomies, but really depends on whether it's a tibial factor or a femoral factor valgus malalignment. So this is what our patient had. They didn't really care so much about the trochlear dysplasia. She's had an MPFL reconstruction. So this is a suture anchor in the patella. This is a bioabsorbable screw from the MPFL construct in the femur. And then she also had the tibial tubercle osteotomy. And just to show you some nice intraoperative pictures of what that looks like, this is an oscillating bone screw. This is underneath the tibial tubercle. So they're going to release a bit of bone, move it across, and then they fix it down with both plates and screws. So hopefully I've given you a quick run through of patellofemoral pathology and different ways in which you can think about how these patients will present and how the surgeons will risk stratify them. Thinking about the importance of radiology, there are a lot of rulers, ratios, and angles that we can measure, but I think it's really, really important to find out what your local surgeons want, because that's most important, that they understand what you're trying to communicate. And then thinking about treatment now, the idea that first dislocators will always be treated conservatively and non-surgically is not really true. We're moving more towards surgical options. And then thinking about your MPFLs, TTOs, and I think the new thing really is thinking about osteotomies in patients with excessive valgus alignment and femoral torsion. And also just highlighting, trochleoplasty is not used that often. So as much as we obsess about trochlear dysplasia, maybe we can relax a little bit about that and just find out what your local surgeons want. Thank you so much.
Angela, that was amazing. Thank you. I'm going to jump in and ask you the questions I have just since you just gave that talk. So I think you answered the question about what can you do if you can't find the landmark for the TTTG. I wasn't even aware of this alternate measurement. But when you can find the the depth of the trochlea,
Mhm.
have found in our own practice where the TTTG distance can vary depending on whether the knee is extended or flexed in any degree. One of my colleagues was called about dramatic differences in the measurement. When you report it, my solution was to report it and comment on whether the knee was extended or the degree of flexion. Is that how you deal with it?
That is exactly how I deal with it. And the other thing is I don't decide whether it's normal or abnormal. So what I will say is the TTTG on MRI in the knee in flexion is X. TTTG on CT with the knee fully extended is this. And then the surgeons know how to interpret that. And I mentioned this to one of the surgeons. He said, we really don't chase a small TTTG difference. We're looking for something very, very elevated, high above over 20, and our correction will be minimal. We're not going to go for an ideal TTTG of 10 or whatever, because there's a risk of overcorrection or complicating things further. We're going to aim for 15 or 16, which in radiological literature would actually be within that sort of abnormal or borderline range. So, yeah.
Oh, great. So, Elena, do you want to jump in?
Yes, there's one question for Renata. How PMR imaging findings be reliably distinguished from findings in other conditions like septic arthritis and early osteoarthritis, Renata?
Thank you, Aline. I think sometimes it's really difficult, but especially for osteoarthritis, I think we usually don't expect to have such severe capsule edema extending around the muscles. It's mostly the changes are mostly within intracapsular and not really extending beyond that. For septic arthritis, though, can be challenging, but one thing that helps is that usually PMR is much of the cases they are bilateral, they are symmetric. You're gonna have other joints involved, so it's clinical. The clinical aspects help a lot on that. So, but both may have this capsule edema. You may have edema around the muscle, so that's what may complicate a little the image differentials. But when you look at the big picture and you see that it's not bilateral, the pain is just within one joint. It's not this so systemic. disease, then we start like getting to the right diagnosis, and it helps a lot in the differential.
You. There's one question for you as well. Does the appearance at the shoulder overlap with adhesive capsulitis?
Oh, definitely. It's really hard in those cases. And I think like for adhesive capsulitis, we do, of course, we have a lot of edema in the capsule, but what we may not have is this extension towards the muscle bellies, towards the myotendinous transitions, and we see that a lot in PMR. Again, both can be bilateral as well, but PMR, most of the cases are bilateral, while adhesive capsulitis, I'm not sure about how many, a lot of them can be, but
I found
you did? You looked that up?
looked it up, 14%.
Good.
And in fact,
14, that's
I
good.
know in my career, I've reported bilateral adhesive capsulitis on a couple of occasions, and now I'm thinking in retrospect, I was wrong. It must have been PMR, but I don't know.
Maybe, yeah. Well, it's hard sometimes, but well, if it's just 14%, it makes easier, right? So usually PMR, like most cases, are gonna be bilateral, and we're gonna have this edema that is really extending beyond the capsule. And of course, not all the cases are gonna be classic.
Interrupt, but I was confused by the clinical criteria that it seems to preferentially be based on shoulder symptoms.
It does. This last criteria, it's from 2012. That one of the required findings is shoulder pain, and then the hips come as secondarily. But what I see is at least the most convincing imaging findings that I've seen in PMR cases, they are in the hip joints. And the most recent papers that we have been seeing, they are really they mostly focus in hip findings. I guess they are a little bit more specific, but there's still a lot for us to learn about that. And well, it's hard to tell, but classically, the patients do have usually bilateral shoulders and hip changes, but of course, not all patients are gonna have that. So it's hard sometimes. It's also, there's not a lot in the literature, especially in the radiology literature. So when you look at in hematology papers, they talk about PMR. It's a very common condition. They consider one of the most common inflammatory disease among patients with 50 years old or more. So it is pretty common for them, but it's just weird. Like we as radiologists, we don't see that a lot, or we don't think about that a lot. At least I didn't. So anyway, there's a lot for us to learn, but this is what we know so far, I'd say.
Renata,
Fantastic.
I'm curious why one of the patients underwent PET-CT.
They do get PET-CTs pretty frequently, mostly because we have this association between PMR and giant cell arteritis. And sometimes, especially if the patient does not have this classic excellent response to low-dose steroids, which is also very characteristic of PMR, the clinicians start to think that they may have associated giant cell arteritis. So they ask for the PET-CT because it helps spotting giant cell arteritis. We can see like this, we have this comprehensive evaluation of the larger vessels, and also a comprehensive evaluation of all the joints on bilateral shoulder, hips. So it helps a lot when you're thinking about PMR. Of course, it's expensive. I mean, I'm not getting into that, but clinically thinking, it can be pretty helpful because you have this general overview of the joints that are involved and an overview of the vessels, and you can help you exclude giant cell arteritis, which is a pretty morbidity condition, like they can cause visual loss and everything. So they usually ask PET-CT for that quite a lot. At least back in Brazil, they did a lot.
Okay, thank you.
So
Hillary?
there are several questions for you, Angela. What is the role of advanced imaging such as 3D MRI or CT in evaluating anatomical predisposing factors like trochlear dysplasia or patella alta? And when should these modalities be preferred over standard MRI? That's actually from Aline, but I thought I'd read it for her. Oh, we can't hear you again.
Excuse me, I was speaking Portuguese with the secretary of our society. Milene, tem que mute dela. por favor.
We have to unmute. We have to unmute Angela.
Tem que desmutar a Ângela para ela responder, por favor. Ela está no mudo e não consegue se desmutar. Milene?
Anfitriã, ela consegue sim. A quem? A Ângela?
Ângela Atinga.
Angela. Ah, acho que ela caiu e voltou, desculpa. Sim, pronto.
Não, ainda continua.
Não é a Angela Atinga?
Aham.
Então, ela é co-anfitriã, ela pode abrir o próprio microfone.
Mas você consegue abrir para ela ou não?
Não, eu posso pedir para solicito e ela abre.
Perfect. Sorry about that.
Agora ela abriu, ok.
It's a reflex. So the 3D is interesting, and we're starting to do a little bit more of 3D imaging. From our surgeon's perspective, the CT provides them a lot of the 3D information, and if they're going to operate, they would prefer to do it on CT than MR. I think they don't have the confidence yet with 3D MR. But also, interestingly, some new research that we're just starting, we have a huge joint preservation service, particularly for patella instability, is looking at just simpler ways of measuring patella alter. So using just the AP, for example, because most patients can get a good AP without flexion, and trying to figure out a ratio that we can get from that just as a better assessment of patella alter, because we know the lateral projections are never perfect. Techs really struggle, patients are in so much pain. So I think both of those are valid methods, and certainly 3D, we're trying to increase our surgeons' confidence with 3D MRI versus CT, but it's a slow process. And we have a huge hip service here, same problem we have. They're going to do a CT even if the patient is 16, 17, because they say if they're going to operate, they need to have the exact information they want.
Okay, a couple of more questions. Pablo asked that he says it's interesting that the surgeons take into account both the Ketan Deschamps and the Insal Salvati. Do you have any insights into why?
So I would say that they don't take into account the Insal Salvati. That is very much a radiological thing rather than a surgical thing. Most of the surgical literature is published on Ketan Deschamps, and that is what most of them are using clinically.
Okay, and Jenny Bencardino asked, has lateral patellar retinacular release fallen out of favor in the management of patellofemoral instability?
Yes, as an isolated procedure, yes, but lateral patellar retinacular release is used in combination with all the other procedures. So for an MPFL reconstruction, in order to mobilize a patella, they do a partial lateral retinacular release. Same thing with tubercle osteotomies to medialize. They have to release part of the retinaculum. But as an isolated procedure, there is no indication for that in its own, because your problem is the patella is lateral. So releasing it, you're going to make it even more. Yeah.
I know, I never really understood that. Okay. And Paulo Noronha says he's come across a few cases of children or teenagers with typical history or typical bone contusions related to recent patellar dislocation, but no edema or obvious tearing of the MPFL or retinaculum. He wonders what your experience is and if he's just missing the tears.
The edema component is interesting because we discussed it at OCAD, just, timing of imaging. If the history is there, patients self-reduce a little bit quicker, maybe the edema takes longer to develop. The MPFL thing I find very interesting in children. I've seen that a lot with very clear history of a dislocation, had to be maybe reduced even in the emergency department, but the MPFL seems intact. I'm not sure that I have a good answer for that. I don't know what you think, but I've seen that more frequently than not.
I mean, sometimes you look and you can't see a tear.
You just can't see it.
But the MPFL seems stretched, but of course there's like no normative data. So yeah. But
Probably comes
I
down
think
to
the surgeons
clinical.
actually acknowledge that it can be stretched without torn. And if there's a focal tear, they may deal with it. But if it's, diffusely stretched, it's dealt with differently. Yeah. Anything else, Elena?
Yes, there's one more question to Angela. Do you see any significance in the shape of the patella?
That's a good question. So recently published data in pediatrics shows that, trochlear dysplasia and patellar morphology are combined the same way you think about hip dysplasia. So the femoral head must be engaged with the acetabulum in order for them to develop normally. And when they don't, they both look abnormal. I think we're seeing that more often than not, but it's not a big area of research, because what are you going to do about it? You're not going to refashion a patella in a young patient with cartilage that is normal. I have seen some patelloplasties, but those are patients who are a little bit older in them, sort of late 20s to 50s, who have severe patellofemoral instability. They will refashion the extensor mechanism, maybe do a little bit of a patelloplasty, but I don't know that there's much else you can offer. So there's not a lot of research from the surgical perspective into that.
Thank you. Wow, I think that's all for today. Thank you all for joining us. And the next session will be May 16, and it will be a joint session with orthopedics and radiologists. So mark your calendars and see you there. Bye-bye. Thank you so much.